is a scheduled program. So the first live case will be performed by Professor Kornowski from Israel. So we'll be going over live to Israel now.
Hello India, hello Hyderabad. This is Rabin Medical Center in Israel, Beilinson Hospital. We are truly delighted to have this opportunity to make this live transmission for your course. I would like to thank all the organizers and especially Dr. Maddury for the opportunity. We have prepared for you very interesting cases, and I would like to present the team. On my left, my colleague, Professor Abid Asali. On my right, Dr. Hannah Vaknin Asa. On my right is Dr. Leo Pearl. We have an extensive team here of nurses headed by Mrs. Nurit Shor, anesthesiologist, Dr. Chinchuk, echocardiograpist, Dr. Shapira, and an extensive backup from our technical team. The first patient that we would like to present is a patient, an elderly patient with critical aortic stenosis, and we are going to present to you how we perform a TAVI case, and I would like to ask Dr. Pearl to present the case.
Thank you, Professor Kornowski. So the first case is going to be a transcatheter aortic valve implantation in a 90-year-old female patient. The patient is a 90-year-old female widow, mother of 4. She was regarded as having a high functional class. In 2011, before a orthopedic surgery, a total hip replacement, the patient had undergone cardiac evaluation, and during that evaluation, a severe aortic stenosis was revealed. The peak gradient was estimated at 110 millimeters of mercury. The mean was 70. The calculated valve area was 0.5. As you can see in this echo, the LVOT from the transesophageal echo, you can see restricted motion of the aortic valve leaflets, severe calcification, and the biplane modality. With that information regarding the cusps, you can see a 3-cuspid morphology with severe calcification. The continuous wave Doppler would establish the severe aortic stenosis with a maximal peak gradient of 111. The mean, as was stated before, is 70 millimeters of mercury. So in order to perform the emergent orthopedic surgery, we decided to go ahead and proceed with a balloon valvuloplasty procedure prior to the orthopedic surgery. The procedure was performed using a nucleus percutaneous valvuloplasty catheter balloon, size 22 millimeters. This was the procedure done in 2011 successfully. And the results of the balloon aortic valvuloplasty was a reduction of the peak gradient from 72 millimeters to 48 millimeters of mercury. The peak-to-peak pressure was reduced from 74 to 36 millimeters of mercury. And this enabled the orthopedics to perform the hip surgery, which was carried out without any complications. In fact, there was a need for a repeat orthopedic surgery later that year, which had undergone successfully as well. The patient remained asymptomatic for 4 years until recently She had started to suffer from recurrence of symptoms. She was dyspneic. There were signs of congestion. And we've performed a repeat echocardiograph study to establish the recurrence of the severe aortic stenosis. In fact, numbers are suitable for critical aortic stenosis with a gradient of 125/82 this time, and the aortic valve area, which is not indexed, 0.4 centimeters square. Here are the continuous wave Doppler examination numbers, the 125/82. It's important to know that there's also severe MAC calcification of the mitral annulus with mitral regurgitation, which was evaluated at moderate intensity with good LV function. The coronary angiography showed no obstructive lesions. And we've performed a computed tomography study, as we often do. And there's a lot of information we can gather from that examination. First of all, the annulus, the size, the dimensions. You can see the aortic valve calcification and the different cusps, and the anatomy and the size of the aortic root. In this case, the diameter was estimated at 23.7 millimeters, and the perimeter 74.4, all suitable with a core valve device size 26 millimeters. We also used the CT to show the peripheral arteries as we have done in the angiography. We showed the femoral and the iliac arteries, and as you can see, there are no significant stenosis. So our treatment strategy today is to perform a TAVI in an elderly, frail patient. We'll perform it with the transformal approach using the core valve, 26 millimeters. You can see it in the open conformation to the left and within the delivery system on the right. We think there is no need for a pre-valvuloplasty. We'll use the direct approach. And for the vascular management of the femoral arteriotomy, we'll use the ProStyle system with contralateral balloon protection.
Thank you very much, Leo. And any questions up to this stage? Okay, if there are no questions, we will proceed and we'll show you. We have started to do a few things before we went live. And the first thing that we did was to stick the right femoral artery, which you see here on the screen. But this is an access, a contralateral access actually. Then we made an angio of the left side, which would be our target for the sheath insertion. Then under vision, fluoroscopic vision, we sticked, as you see here, we stick the left femoral artery just below the inguinal ligament, maybe a little bit higher. No, I think it's right there. And then we exchanged the 6 French sheath into the ProStar device. We made the suture of the ProStar. This is the pacemaker, sorry. Obviously, we want the backup of the pacemaker, which would be important for the implantation phase if we need it. Not always we need it, and afterwards, if we have any conduction abnormalities. Then this is the exchange for the ProStar, as you see here. And after we establish the 2 sutures of the ProStar, we exchange for, this is the ProStar you see here, and we exchange the large 18 French hook sheath that we place from the femoral to the iliac into the abdominal aorta, somewhere between the abdominal and thoracic aorta. And then what we did was we made an injection to delineate the aortic root. You see heavy calcification of the aortic valve. There is also severe MAC, mitral annular calcification. We freeze this injection, which would be our landmark for the implantation. It is very important to be as perpendicular as possible. And we have also information which is derived from the CT about perpendicularity. And the next thing was we have crossed the aortic valve using an Amplatz left 1, you see here, into the LV, next frame. And then what we did, we exchanged into a soft wire and placed a pigtail catheter, which is what we have right now in the LV. Meanwhile, we have also prepared the valve, the core valve. It's a 26 core valve, which is self-expandable. It is a very sophisticated technique that we have used for the last 7 years in our center. And we feel very confident about the performance of the device and the valves, and we are going to show you how we position this device in the annular region, and it is a self-expandable device. We open the device in the annulus, and by that we open the leaflets, the 3 leaflets, which are pericardial, porcine pericardial leaflets, and the valve starts to function early on, and we are going to show you the process live. So the next thing we would like to do is to, first of all, you can see also the hemodynamics, which is pretty impressive. You see here the LV to systemic pressure gradient, which is around 80 millimeter. This is a very high peak, which is also compatible with our diagnosis of critical or very severe aortic stenosis. Can you see that on your screen?
Yeah. Professor Ran, can you hear me? Hello?
Yes, I can hear you.
I'm Dr. Rao. How are you doing?
Hello, Dr. Rao. Pleasure to communicate with you.
Yeah, Ran. So, Ran, first of all, why did you choose a core wall over this Edward Sapiens? Any reason for choosing core wall?
We have extensive experience with both valves, including some other valves, but due to the heavy calcification, relatively small annulus, we also look at the distance from the coronaries. We look at everything, actually. We thought that it would be safer to do it using a core valve 26 millimeter. Doesn't say that we cannot do it with another valve, but this was our choice in this case.
Yeah, what was the annulus size, Dr.
So,
Ran?
yes?
What is the annulus size?
The annular size by CT is around 19.7 over 25.6, which is an oval-shaped, relatively oval-shaped annulus, very typical, 3 leaflets, a lot of calcification, massive calcification. The mean diameter is 22. both by perimeter and by area and by TEE. So it is very suited for the 26 millimeter core valve. Now we would like to proceed with implantation because the patient is a bit unstable. Now we have here the stiff wire, the super stiff wire, which we actually made this shape. You see it? The shape of the wire that should be placed in the LV. So we make this safety configuration to avoid any problems in the LV environment. So,
Professor Ran, is there any wires which comes with Professor Ran, is there any wire which comes with the pre-shaped one?
There are some new wires which we have used. There are some new wires that are pre-shaped, and in this case we elected to use a manual shaping that we have a lot of experience and confidence with. But obviously we can use a pre-shaped wire here as well if we need.
Ran, this is 035 or 038? Hello?
It's a 035 wire.
The exchange code. The exchange.
Why did you choose left groin to put your sheath in? Why not from the right groin? Is there any specific reason?
According to the CT, the left groin was a bit wider compared to the right groin in terms of dimension and classification. I think we need to, okay. And we thought it would be, and it was also less angulated, so we thought it would be better to go through the left rather than the right groin. Okay, so Abed, you had some difficulty in terms of...
I think it was catched in one of the cordas, so we have to release it. I think it's okay now.
Now it's okay. Okay, we are now in RAO projection.
Are you planning to do the PPAV once again?
The what?
Are you planning to do the balloon dilatation now or directly wanted to go for the self-expanding stent implantation?
We'll try to do without pre-dilatation. Our strategy over the last, I would say, year and a half has been not to do pre-dilatation in the vast majority of cases, and we don't think this is necessary in most cases, including in this case. I hope we are right. We have extensive experience in around 150 cases consecutive that we have done without the pre-dilatation. Now, after we have placed the wire in the LV, we have the core valve that was brought to us now. It was prepared just now. What you see here is the core valve, which is wrapped here and crimped. Now, actually, you see everything is in a capsule. Yes. This is actually most of the shaft is a 12 French device. The tip is approximately 18 French, and this is the reason we need an 18 French sheath. And you see here the sleeve, you see the nose cone, and this is a handling device where we can unsheath and open the core valve in place, and we are going to demonstrate to you how we do that in a few minutes from now. But the first task would be to insert the core valve into the sheath and to take it up into the aortic valve area. So Abed, maybe you can describe.
So now I'm introducing the valve, unsheathed valve, into the sheath, and the valve is getting out from the sheath over the stiff wire, okay, going around the curve very easily. Okay, and now we are approaching the valve.
Some tension into the wire a little bit.
Okay.
Do you take any precaution when you
Now we
are
are
turning
crossing the
the
valve. Think we are crossing the valve now, and we are trying to find the right height where we can begin. Can you give us some contrast, please?
Ran, when there is extensive calcification, people recommend balloon dilatation before inserting the, is it so? Because otherwise the
I know, I mean,
post-operative or post-procedural,
I know, but we are not too much afraid. We are not too much afraid of the calcification, and I don't think the pre-dilatation, which is usually a gentle pre-dilatation, makes much of a difference. And if needed, we'll be able to do post-dilatation afterwards.
I think this is a good place to start.
Okay.
We're a few millimeters below the annulus, and we can start doing this here.
Yes. Maybe we can push a little bit on the wire, just a little bit.
This is what I'm doing.
Okay.
Okay. Now we can start.
Are you going to use the Pion system to know the alignment and then implantation?
We are going to start the implantation right now. Hannah is actually opening. If you can point to her hands just for a second, she's doing a clockwise rotation of the device, very, very slowly. Slowly, that's a very important principle here, to do it slowly. It's a bit deep. I would put some more tension. Yeah, a little bit, not too much.
Okay.
Continue.
Now you start to see.
You don't do pacing while releasing the valve.
You start to see. Let's focus now. Let's focus.